I learned very early in my practice that I had a very good face for radio. So I'll move around a lot so you don't have to keep staring at me. It's much easier for you that way. Let's begin on our morning together. I don't know the schedule or agenda, but I have about 120 some PowerPoints. Again, I'm kind of an overly compulsive person. I always like to be prepared in case somebody asks a question. So hopefully I have a PowerPoint, at least 10 for each of you, the way it looks, for the morning. And why don't we just, as a community, holler up when you want to take a break, a little bit of a break. Since I think I have to finish up about 10 minutes to the hour. And so let's pace ourselves for breaks and things like that as well. I'm not sure when the conference has it set up in the morning time, so let's jump in. And the other thing I suspect that most of us have a variety of clinical experiences, clinical practices, and clinical training. And ADHD is one of those areas that just craves controversy. Okay, who is, who isn't? And those are really the two basic questions that we have to deal with in practice. Does this person have it, or does he, likely is he, not have it? So let's kind of walk through those controversies and have some fun with it this morning. My approach tends to be more theoretical. So let's jump in. And since it is a nice community, just feel free. You don't have to raise hands and say, please, teacher. But just jump in with a question if that's okay with the community. If it gets out of hand, we'll say something. But let's just work as a community back and forth, dialoguing. There are multiple models to explain ADHD. Two of those tend to be prominent if we look at what's being said in the research, what's being said in the writings. And there's probably a third one, and that is what people do in their practice, which is probably not related to any of those two. And that's probably the thing we need to talk about, because as far as I'm concerned, I think we really need to focus our treatment back on these two issues here. I'm going to spend some time talking about Barkley's and Gordon's model, and then Tom Brown's model as well. Now, the big thing we're going to look at, again, is this last part, and that is sustained attention. And sometimes you'll hear it called vigilance. And executive functioning. Well, that's poor grammar. It's are multifaceted. And very, very difficult to map for ourselves. And those are the real questions. Is it really a problem with sustained attention? Is it a problem with executive functioning? Is it an interacting feedback loop? Or is it none of them for ourselves? And let's take a look. Let's take a look at some historical models. First of all, attention is not a nice, simple psychological construct that's neat and tidy for ourselves at all. It's not unitary in that point. And if you work with ADHD children, you'll realize that, well, there's similarity between all of them. Every one of them is different at the same time for ourselves. So we have to struggle with this idea of what is attention. So we have to come up with ourselves in our clinical practices as to what is then this construct of attention and impulse control. What is the construct that we use to define the problem? Zubin, back in '95, conceptual as having basically attention has multiple components and or multiple elements. There are psychiatric models. And I think if we look at clinicians and poll them, this is an underlying assumption that many of our clinicians make, and that is attention is a process that controls the flow of information processing. It's anything that disrupts that information processing. And as we'll see in a little bit, it's really this one here, this last one, that forms the basis for Tom Brown's work at Yale. And that is, attention is anything that controls the flow of information processing. Now, having said that, and I was just chatting with folks early before this morning is that if we take a look at that last one, and if we have children, even adults coming in with problems with sustained attention that interrupt any kind of daily living, well, just that statement alone, that sentence is, I believe, the first two sentences in DSM-4 for depression and for anxiety disorders. There has to be some disruption of sustained attention and concentration in everyday living. So if we take this psychiatric model, then we're going to have to be really careful, because technically then ADHD could be depression or anxiety, and if we look at DSM-4 standards, it's not for ourselves. So we have to be careful in how we conceptualize sustained attention. There are some aspects of that psychiatric model, though, that are important for us to include in our conceptualization. And that is, attention often is selective. There's an element of selectivity to sustained attention. And you'll typically hear that assumption and that model rising up from clinicians as they dialogue with parents, saying, well, certainly he can pay attention to video games and Nintendo games. There is selective attention. And parents, as you know, always ask, how come, Johnny can do so well and get 3,000 points a second on some video game, but in the classroom or when he's listening to me, he can't do so well? So the element of selectivity rises to the surface. And there are multiple reasons for that. And I don't know if all of you are on list servers for clinicians, like I'm on one for pediatric neuropsychology, and there's an adult neuropsychology list server. If you're interested in those, you can just go to like the APA and go into the divisions and you can find those sources. But the chatter is quite interesting, because these things often come up, and if you listen to other, even renowned neuropsychologists talking about it, we realize that we haven't a clue to really answer that question, why Johnny can play video games so well and do poorly in the classroom. Simply, novelty is an important issue, rewards are an issue, and fun is an issue. But I don't think we still have a good, solid theoretical reason as to why that works. Because if you listen to the chatter from the pros, there are multiple models. I do think we need some much better research on this, and I would like to see some studies looking at, brainwave functions while playing and then while not playing on these individuals, and see if there are peak differences. But there's perhaps a variety of explanations. But the issue for us this morning is selectivity is a key issue for ourselves. We also have to take a look at capacity. Back up a second. Capacity is essential also. Does the individual have the capacity to sustain attention? That gets into developmental issues for ourselves. Obviously, a 3-year-old has less capacity to be vigilant than does a 9-year-old, theoretically speaking. Okay, for ourselves. And so capacity is an issue. And that's why when you work with your patients, you really must delve into history. History is a critical predictor factor in ADHD diagnosis as well. But capacity is an issue. And then the other issue of what is sustained attention, sustained concentration itself. I mean, both of those two interact to provide the last one, which is sustained concentration for ourselves. However, from the psychiatric model, those disruptions can come from anywhere. That an ADHD child has a disruption of selectivity, disruption of capacity, or disruption of sustained attention, the interaction of those two parts itself. Neuropsychologists typically conceptualize attention as really two domains, and are not dissimilar from the last one, but selective processing and awareness of the stimuli itself. And so the selectivity issue rises in place as well. Now, if I recall, a little bit we'll get into some Leark models for processing, but we have to bear in mind that as we're created and developing, that first area, brainstem development, is one of the first areas that develop conceptually for ourselves. That also is good for us because we have hearts and lungs and everything else that are necessary for life. But we also then overlay on that some element of inhibition and control so that we can focus ourselves, even as infants develop, into what's necessary to survive. So we have to keep that survival idea in place for ourselves as well. But we do develop selective processing components. And I know there are questions, and I remember early in my life, and in the ADHD work, I'm old enough to remember minimal brain disorder was a minimal brain development and disorders were really a marked shift in how we looked at sustained attention. And then we got into, of course, ADDs. Then we got into the ADDs with the H's and without the H's. And then we put the H back, and then we took the H out, and we carved it underneath something again, and now it's there. But it gets into that idea is that when we made that shift to minimal brain dysfunction, I think that really helped us look at where does the selective processing component come from. We began to see that, yes, it does have an organic component to it. And that's essential for us, for ourselves. And I say that repeatedly, and it may seem like, duh, why is he saying this to us? We know that. But I'm very fortunate enough to do work, in Europe and other places. And while I do have German heritage in myself, from both sides of the family, I'm all German, my German colleagues still insist that you can't cure them until they have character. And that if you treat the character, you will change the ADHD child. And thus the analytical model is still the preferred model for treatment in many areas of the world. Now, certainly I think people need character. My definition to them of character is what you get when you did not get what you wanted. But as analysts, they didn't like that one. And what they typically like to see is, again, much more play therapy-oriented models. Good luck. Okay. What that does is that eliminates then selective processing and even stimulus awareness. It takes it out of the organic component or the neurocognitive component. And I strongly encourage you to keep that link in there for yourselves. Now, what do we mean by attention? Well, and initiation is a key component. All of us are operating constantly 24 hours a day. We're on. We're never really off. We sleep, we come to lectures, we see boring patients, but we're never off. We're always on. Our system is always on the go, ready to respond. It's a nice ready state unit for ourselves. And so at some level, attention is always like a nice radar system on, and the screen is always working for ourselves. Something comes into that radar screen that alerts our feedback mechanisms that we have to respond. Normally, what we do then is respond. We rise up in the arousal level to meet the demands of that situation. As you know from flight or flight, sometimes we go a little bit overboard and then we rebound back down, but we rise up to the occasion to meet that. I remember in my early days of training, we used to think that ADHD was because these individuals had an oversense of arousal, that radar screen was always on and they couldn't tell a blip from a non-blip on that radar screen. They were always on. And thus the idea is that reticular activating system, which is really that radar for ourselves, was always on. It was going too fast. And then the way to control that then is to give some medication, which brings that radar screen back down to normal processing. And I'm using some metaphors, of course, but I think the model is understood. The other component that then also existed is that now what really is going on, that radar screen isn't going too fast, it's going too slow in these ADHD children. And what we must do then is speed up what life has a habit of doing, like seizures, it's kind of wake-up calls to ourselves, is jumpstart that system to keep it moving at regular pace. And so we kind of have one side of the coin and then the obverse side of the coin at this point, looking at that same issue. And the issue really is that the pace of that radar screen. And that's an interesting model for us. I think there's some reality to it. I mean, we do all have that built-in radar screen, as I'm calling it, the reticular activating system, and that does seem to be preset by genetic factors during our developmental era. When we tap that developmental sequence with other environmental consequences, especially in neonatal periods, that radar screen becomes altered. So we have different potentials coming in at any time of that genetic sequence to change the pace of that normal operating radar screen. So it may well be that ADHDs have different reticular activating system processing. It may be that. It may also be that those who are depressed have that also, just on the opposite end. But that is one model for us to take a look at. Again, listening to the chat rooms from professionals, that model streams in when we start talking about Johnny playing video games. That there's an attenuation that goes on to the radar game because those video games are pretty fast-paced. You know, I'm still on Pong and mastering that thing. But with I'm not older than all of you. You remember Pong. You cut out of classes to play that game too. Is that those things are pretty fast-paced for ourselves. But each time it's a fast pace, we also have novelty being entered in. And if your radar screen going on, and you add novelty, it blips up, and there is some sense of stimulus pleasure going on at that point also. We have to take a look at. But I think it's important to get back to the idea that history taking can tell you something about that individual's, again, I'll just call it radar screen, the reticular activating system we want to look at really the developmental model for it. It'll tell you that. That's why you also have to take a look at the genetic tree of that individual. That will tell you quite a lot for ourselves. Because that screen then leads us to the next part is then sustained attention and vigilance for ourselves. So first we have to be aroused. We have to have something occurring, and that's a steady state 24 hours a day. And then we have to have the ability to hone in on whatever it is on that radar screen for ourselves. Now, again, there's some nice animal models for that. If we look at just developmental animal development, certainly if we look at from a general evolutionary sense, if you're a rabbit out there in the forest, you're paying attention with those big ears a lot. They can rotate around. And you learn to then look in directions of sound. Again, those are reticular activating system units, or if you're a Lurian model, that's a unit 1, zone 1, 2, and 3 capacity to take a look at that. We developed then a system to focus. Then we can have sustained attention. Then we also have an overlap feedback to orient ourselves to whatever it is going on in that direction. This is what begins to differ for the ADHD child who can play video games very well and may be able to be aroused, but classroom stuff, there's a lot of just distractions, if you notice. So that he or she, and again likely he, can hear the big wolf coming in the forest at him, but he doesn't orient to the location. He's still out in space somewhere playing the game or on the bookshelf, not able to get back down to earth, so to speak, to realize the danger upon himself. And again, using it as a crude analogy for evolution, if you're that animal, you don't live very long. It's kind of like one trial learning to the wolf. Okay. And if we think about ADHD children, they clearly fail to profit from experience the majority of time. Fortunately, there's not a lot of wolves. And I say that fortunately because there still are some wolves around in the classrooms and everything else, and they end up getting in trouble. But the good part is they get sent back to the woods, so to speak, and they try to do it over and over, and they fail to profit. And I think in part because they can get that blip on their radar screen, but they fail to orient to that model for ourselves. And so again, when you look at your history, look at the radar screen, and take a look at that early life experience. When your child was growing up, how did he profit from self-correction, from correction? When you redirected him, did he redirect very easily, or was he just distracted constantly? Did he fail to learn from redirection? Those are important clues when you look at history tape for yourself. Now, since we do have women in the room, guys, I'll just say the obvious to them is that please understand, women, that we guys often just fail to get redirected. That's just part of who we are. We kind of just hear the clues and go our own ways anyway. So allow for a little bit of maleness to overload that. Okay. That leads us then to this third part, inhibiting responses to irrelevant stimuli. Again, if redirected, do they go back to the wrong task? Can they sustain the redirection? You know, as you work with parents, you hear a lot from them. They talk about, my child doesn't respond to discipline, for example. And then I ask them for a definition of discipline, and of course it's usually spanking, hitting, or some timeout or something, some chain of things. And I, being kind of a goal-oriented person, I always remind them, well, what is the purpose of that? Well, so that he learns. That's right. The reality is discipline is imposed so that ideally the individual self-disciplines. That's really the outcome of any kind of redirection, is so that that organism begins to redirect. At that point, self-discipline takes in. Self-discipline comes in if we can inhibit responses to those irrelevant stimuli. We begin to show signs of that self-direction and self-inhibition. Okay. We then can have alternating, shifting levels of attention that help us. ADHD children really have problems in all of these areas. And again, since I come from a Learkian model, every one of those can lead to a break in that link of behavior anywhere along the way. Our goal is to come in then into a history, assess whatever magic trick we have in our bag to look at where is the problem for ourselves. Okay. Again, feel free to jump in. I see some of you with questions and things, so feel free to jump in. But this really is a model that continues to be developed for ourselves. Now, the reality is, while saying sometimes we should do some testing, we don't have a lot of excellent tests for all four of those areas. You know, we neuropsychologists are very good with grenades, okay, but with pinpointing sometimes we're off a little bit. Okay. So be careful still on overgeneralizing results from tests, because again, they tend to be broad-scoped measures for ourselves. And make sure that you can hone in on certain areas. And again, history becomes an important component. But the other element to remember is that this really gets back into this broad feedback loop, is that we have an individual developing who, by what we call normal life, with some redirection, develops an ability to self-direct that individual. That's the problem with ADHD kids. That link isn't right. Now, let's take a look and continue to develop this model. Cynthia Riccio, Cecil Reynolds, and Patricia Lowe from Texas A&M University. And this book is actually a wonderful book, because I'm going to get in the latter part of the day or the morning into continuous performance tests. That's really what I like to do. I help develop them, so you're going to get what I know this morning a little bit. But their book is actually a wonderful book entitled Clinical Utility of Continuous Performance Test. It's through John Wiley. I think it was published last October. And they've done a wonderful job not only in looking at all the CPTs that are out there and summarizing probably 500 articles into a book, but before they get to that, they do a wonderful job of summarizing about another 500 worth of articles on sustained attention. So they do a wonderful job of getting you up to date and doing all that work for you in the typical Riccio and Reynolds model of getting that ready for you. Their research and their review of the research shows that what most theorists look at, again, coming from neuropsychological components, are similar models that we just begin to talk about. What are the areas we talk about in research? Arousal, selective attention, sustaining attention, shifting of attention. Very similar to that last screen I just showed you. This fits into it. Arousal alertness. Taking a look then at motor intention. Motor intention is a major issue. Often, let me use a better word, sometimes, let's go sometimes. There's an element of an inability to inhibit motor responses that produces ADHD-like behavior. And there's a lot in the world that is ADHD-like, first of all. And that's why it's your goal to tease out what it is and what it isn't. But if you cannot inhibit motor responses, it may not be because of those other elements we talked about with the reticular activating system at all. It may be related to either peripheral motor functions or feedback loops from the motor control areas. So there is research looking at this motor inattention and motor initiation going on. Initiation is that task initiation. Now, ADHD children typically don't have problems initiating motor tasks. That's that H one we talked about that floated around in diagnosis and what we called it for a long time. But that H problem typically dissipates around 7, 8, or 9 years of age. We expect the H, the hyperactivity, to be more of a problem in younger children. So at some point, by nature, just the way I'll describe it, children should then have some initiation inhibiting abilities going on as well. So we have to take a look at this for ourselves and take a look. Often you may need to do some motor tasks. Yeah?
Can you give me an example of motor inhibition?
Well, let's look at some of it at a crude end. We look at tremors, for example. There's motor movements that can't be inhibited. All the way up sometimes to difficulties with just impulse control and constant movement itself. Movements, things like that. Actually, probably some things you want to hear later. Do you want to say now about things with impulse control and well, you don't have to, but I'll give you a plug for a great workshop this afternoon as well on what I would call discontrol problems. Do you want to take a minute and say anything? Okay. Come this afternoon and hear it. But with episodic discontrol issues, that could be another issue to take a look at, motor responses and motor type things, and the ability to inhibit those aggressive behaviors. Exactly. Right. Again, those are rarer kinds of issues for us, but there are things you have to take a look at because, again, the typical medication of choice, methamphetamines, isn't really the ideal medication for those disorders. They tend to create more tic-like problems, which exacerbate that problem. Okay. But on the other full extreme of that, intermittent explosive disorders or the discontrol problems have some motor initiation, motor retention difficulties as well. Not all of it, but there is an element that has to be taken a look at. There has to be some feedback loop to stop that or to start it. Okay. So you do have to take a look at that. Okay. You do have to take a look. I prefer to use some of the Lurian test models. Again, I just kind of grew up as a Lurian, and if you school psychologists do like the KBC tasks, this kind of a one task that was out there. Familiar with the KBC, some of you? Somebody nod their head at least. That purple bowling bag you used to take with you as school psychologists? Okay, that got you, okay. He used some nice learning models of hand movements and taking a look at the ability to put those in. I think the word we also like to use is dysdiodokinesis. It's a great one if you're playing Scrabble. But really is that inability to do the motor movements itself and initiate the task and mimic. What you do is you do the task and they pantomime it out for you and take a look at that, those intentional tasks. Or again, even just finger sequencing and things like that. And then work up the chain of behaviors that way. Again, there's a small percentage that are going to be teased out of this ADHD population by looking at motor difficulties itself as the real problem for ourselves. Selective attention is really where the bulk of the research, bulk of the assessment seems to be done for ourselves. The focusing, again, inhibiting and filtering that I talked to several slides ago in the sense of this is really, we take our activating system kind of functioning in the sense of the radar screen, being able to focus on that radar screen. And quite interesting is, if we look back at the days of early psychology, back in Wundt's lab and the work done at Würzburg in Germany, what we see is, and then also I think it was Donder's work in Göttingen and some of the work being done at the National Astronomy Lab in England at the time, was they had individuals who were looking at these astrological functions and doing calculations. And Donder's, and then later the work at Göttingen, and some of Wundt's early work realized is that there were individuals who got fired because the calculations were off. And we began to get into this idea that, wait a minute, maybe there are errors that people make of attention and not mathematical errors. And that really is kind of an early history of how we got into the history of psychology that later went to Wundt's lab, into armchair psychology, which really is a great diversion, but taking a look at individual differences. And that's really kind of the history of who we are as psychologists, and that's really what we do now in our practice. We look at differentness and variance. But this area, focused attention, really is the source of how we grew up as psychologists back in the 1700s and 1800s for ourselves. Looking at this, wait a minute, this person differed. Maybe they're just not idiots. Maybe there really is a construct here. There's variability, a differentness. And we need to take a look at how we can focus attention. Some of Donder's work at Göttingen was done on sustained attention. And actually, if we look historically, becomes the forerunner of what we now have as continuous performance tests for ourselves. So there's some early history of us as psychologists looking at this, dating back to the, again, 1800s easily for ourselves. How do we focus attention? Sustain. And again, as I alluded to earlier, we males seem to be in our own world, first of all, having problems with sustained attention and focused attention anyway. Then we get into this idea of divided attention. And if we take a look at these three areas here, this is really what the classroom is all about. Again, kind of a crude analogy is that when we go to, our life seems to be a way of learning inhibition from the day we're out of the birth canal. What we begin to do is take those responses and excitations and inhibitions and learn to inhibit ourselves. And we go through various stages of learning inhibition. Those of us who've got Ph.D. have probably got the highest level of sustained inhibition and delayed gratification at that point. It's the ADHD that doesn't fit that model that gets so disrupted. Because again, the cultural expectation is inhibition. Classroom activity is really learning to inhibit. You today are inhibiting. You don't have to be, but that's okay. Inhibiting. When can you get excited? When can you inhibit? That also has neurochemical relationships we take a look at. We have to remember that there's a lockstep training mechanism and conditioning that goes on, and in some sense a real Pavlovian model for us to condition ourselves to get to the point that we can have divided attention, inhibit ourselves here, and do something over here. Now, I was too young to have ADHD. It didn't exist when I was a kid. But I really was a PIA. But those of you who do child work should learn that an acronym. It's the pain in the ass. There's FLKs, funny looking kids, and PIAs. I was a little bit of both. Because I would rather play baseball. I was thinking about Ernie Banks. I grew up outside Chicago that day. I wasn't paying attention to the classroom. I had poor divided attention. I still do. I'm walking around up here like a caged animal. I had difficulty sustaining that and dividing it. But it's the core of what you need to make it through school, at least alive. Okay? You need to, I had my fantasies about Ernie Banks, but then I learned to do math. I got better grades in my fantasies than in my math, but at some point I learned to inhibit the action to do the task. That's the key component. Again, when you do history taking, try to tease that down to the child and the classroom. Now, the teacher may not know that, but now, as my mentors used to always say, you have the data, you have the history, by all means, also see the patient. Okay? Spend some time talking to them, finding out how they do things in the classroom. It's going to be important for you to learn. You'll learn some fun things that way also, and kids are great at talking, and kids can be great teachers as well. But divided attention is the key thing. Now, as we look at continuous performance tasks and other ways to assess divided attention, this is again where we begin to break down. Typically, you use the Wechsler scales, which I have to tell you, certainly by Stein's work on the freedom from distractibility, it certainly is a measuring distractibility article from 1997, from what I'll call the Orange Journal, the Journal of Psychiatry, clearly demonstrated that factor analysis scale does not relate to anything at all with regards to ADHD or hyperactivity. It correlates the highest of mathematical functions. Not surprisingly, since what's the biggest factor load on that scale? It's digit span. Okay. It correlated non-significantly to behavior rating scales, non-significantly to continuous performance tests, and every other task of sustained attention and vigilance. But yet we still look at that model. That's really not always divided attention. Okay. So we have to take a look at ways to take a look at that. And we don't always have psychometrically sound ways to do that. That's why histories are very important to you, for yourselves, to take a look at that. But it's important for that child to learn that. We have to have that ability to divide our attention. We have to pay attention to the radar screen. We still have to fly the airplane sometimes. Okay, so we have to have both skills. At that point, we've learned some level of inhibition for ourselves. That's critically important. Okay. It's kind of like being able to drive your car and use the cell phone. Okay. Not that you're supposed to do that, and none of you would ever think about doing that, but divided attention is a problem. Okay. Selective attention has a third element, and that's the encoding, rehearsal, and retrieving mechanism. Now, some may say that's really information processing. Okay. And this is where I probably differ a little bit from those that talk about auditory processing problems in that model. I look at auditory processing as a component of sustained attention because, again, we have coming into this reticular activating system on this radar screen, if you will, we have multiple layers of that radar screen. For every sensory domain that we have for ourselves, we have a radar screen. And so we have to be able to divide our attention between all those different radar screens for each sensory domain. It may be sometimes, and Barclay's one who talks about it with about a 20% factor, and by that I mean those who have ADHD, 20% of the time, Barclay says his research shows, have difficulties with auditory processing problems related to sustained attention. So it's a small subset of a small subset, but it is a subset to pay attention to. And that's that processing difficulty. Somewhere along the line, we have to learn inhibition, and that's encoded inhibition. We have to be able to rehearse inhibition, and then we have to be able to pull it back as well, separate loops. Now, again, if you're Learkian or brain developmentally oriented in that sense, what you really learn to do then is use the parietal lobe areas for ourselves. where we store all that sensory processing information. We can rehearse it. And that's the nice part about what we talk about executive functions and frontal lobes is that last frontier of our life, using a little Star Trekian knowledge, is that last frontier allows us to take behaviors, rehearse them in place, and then bring them back in and retrieve them and use them. 3 different behavioral links. Each one of them can have a problem with sustained attention. We can have a problem with the basic encoding mechanism. Again, a Lurian model would be unit 1, which is the sustained attention model, and then 2 would be the sensory processing and language coming on, and that's the parietals, and the 3rd is the frontal lobe. Yeah, that's that way for you. Any interaction loop between the parietal developing lobe and the reticular activating system really gets into that encoding difficulty. Typically, if there's going to be encoding difficulty, there's typically going to be a retrieval difficulty at some problem also. It's kind of that garbage in, garbage out problem with binary processing for ourselves. The rehearsal part, though, is really thought to be a later stage development, 8, 9, 10, perhaps early adolescence, and so forth. So in younger children, we don't always see the rehearsal problem. But that's an element that has to be there. You can have encoding difficulties in any way. And now I want to take a time out. I'm not a therapist in that real sense. I just don't have that much people skill. The cognitive behavioral model seems to be a nice model to maybe make some adaptations for this rehearsal problem. Are any of you familiar with some of that cognitive behavioral work being done with ADHD? In the sense of rehearsal, in the sense of rehearsing? I know the schools that I'm familiar with used to do a stop and think kind of model for themselves and then act, which is really a cognitive model, which is really a rehearsal problem mechanism dealing with that. The goal, again, though, is remember to get back to that, is to look at inhibition. Is anyone familiar or anything? Feel free to say anything on it. Okay. Well, I'll find out some things and email you down the line. How's that? But that's an element, okay, that we have to take a look at. And I think for some children that may work, but it's not going to work for the coding or the retrieval problem child. Nor is it going to work for the child who has problems with divided attention or focused attention in the first place, if they're base problems. Again, there's a hierarchical link we have to take a look at. Where is the problem in this thing? Now, as I've been talking, what you keep hearing me drum on is this model of organic processing or neuropsychological or cognitive processing. We have to take a look back at where we started at some conceptual models for ourselves. What is the conceptual model we use? As I mentioned, mine is very strong neurobehavioral. It's that element that we have to treat and diagnose in order to take a look at things to make some kind of care, plan of care. Okay. Again, more on history. Brodmann back in 73. Capacity to take in information is limited, he said. Thus, information not relevant needs to be filtering out. That's that radar screen model. Information filtered dependent upon the stimulus characteristics. Again, get back to that radar screen model. The ADHD's radar may not function. And by radar, I'm talking about the reticular activating system. This is one of those, and Brodmann was one of those, to encourage then that model of looking at treating such individuals with medications and things like that. Okay. Now, there's a second model that's stressed as arousal, and that's that back side of the coin that I talked about. It may not be the radar, it may be the other side of the coin. Here, optimal alertness is necessary for any effortful, organized function. Carl Prigran, arousal is short-lived. It's a short-lived response to the stimulus. Arousal is the general state of the individual that allows for and affects attentional processing. So we talk about arousal, but arousal is a process that has little, if you will, atoms to it that short-lived and dissipate out. Because what we tend to do is create an arousal model for an event that's overlaid on general arousal in the first place. That event then fades out because it's no longer important. We have a blip come up on the screen, for example. What do we do with it? We have to pay attention to it. Well, that blip may not be important enough to sustain that arousal, so it's short-lived. And that, again, that's what Prebaum's talking about theoretically here, is that we have to look at that as a short-lived process. Thus, if we look at that radar screen problem, what the theorists are saying is that there's a bunch of short-lived explosive bursts going on, stacking up, that go nowhere for our cells. Using different instruments than Mirsky did, but generally these three factors still come in here. Focusing attention, sustaining of attention, and shifting of attention. The same thing we just talked about for the first hour here is these three factors are a critical issue to ourselves. Okay. And they tend to hold true today when we look at factor analytical driven studies. Again, the definitions are not dissimilar to what we've been talking about. Part of the process of focusing attention, ability to maintain that focus over time, and the ability to shift attention as we need to. Okay. Unnecessary. Again, the latter part is really the part we have to drive ourselves. This is really going to be necessary for us to adapt in the classroom and the real world. Again, one of the real components of life is to learn inhibition. If you fail to learn inhibition, you're not going to do well in our society. Now, I'm going to go into Luria's model for a little bit, and then I think we jump in on getting into the two theorists, which Barkley and Gordon, and then Brown for ourselves. You've heard me talk, kind of nest Luria's model into the whole morning already, but attention is the key component. What Luria basically proposes is that as we develop, there's this brainstem mechanism that develops. That's unit 1. It's 3 phases. And then there's an overlap around it. If you think about, there's a good brainstem, there's a good corpus callosum and medial ventricle. Then where we lay on that is really the parietal lobes and occipital lobes in the back. And in the front we have this bulge up here known as the frontal lobes. Those are 3 units that he talks about. The first unit is the primary one we have to have. It's basic to life, he says. Okay. Each one of the other 2 units provide feedback loops which provide inhibition to the first unit. Okay. So ADHD really is a disorder of unit 1 and then a disorder of feedback loops from unit 2 and unit 3. Now, ADHD, non-ADHD children look like ADHD children when they have feedback loop problems from 2 to 1 or from 3 to 1. So they look the same, but in a theoretical base, there's a level of differentness that's there because the unit 1 one typically meets the DSM-4 criterion, that is, the symptoms are typically there before age 7. They're requisite. They just don't develop at age 35 when you get fired from a job. Okay. They have to be present if we look at strict DSM-4 characteristics. And so the Luria model fits that because developmentally they have to be there. And actually, that system is intact and developed at birth, and you begin to see signs automatically. When I do histories with children, I go back to those days. Certainly my histories go back to neonate pregnancy and looking at any kind of convergence of difficulty genetically, and then go through the 9 months cycle. And then at birth, that first 6 months is so rich in history the ability to develop rhythms. And by rhythms, parents, you know what that means. You get to sleep a little bit. You get to eat regular food once in a while, too. Does the child develop those rhythms? The development of those rhythms really means that Unit 1 is being inhibited. It means it's not only developing, but it's developing some normal inhibition. Okay. So take that history back to those time periods, because those are predictors for you. So certainly the child wasn't climbing bookcases at that point, but development of rhythms is very important. Sleep rhythms, eating rhythms, social rhythms, and things like that are very important. Because what you're doing is, they're not ADHD, but they are giving you historical patterns that inhibition was formed early, or could have been formed early. That's the other key component. Very important. Leark goes on to say one is reflective and non-reflexive, again, orienting and social learning. Again, social learning is just a nice word for inhibition. Luria was very influenced by Vygotsky's work, and so he likes to use social learning as an idea rather than inhibition. Because his other friend, instead of Vygotsky, he had to deal with inhibition because his other friend was Ivan Pavlov. And so he kind of had a nice little model for himself. That gets us into the limbic system and frontal lobe mediation as feedback loops important to that first zone for ourselves. Okay. Does that make sense to folks? Comments, questions? Just yell them out. Okay. That leads then to that frontal lobe area, that last frontier for our lives, executive functions linked to mediating attention. Okay. Mediation, again, is another way of saying inhibiting. Okay. Inhibiting attention. Self-direction, goal-directedness, regulation, response, and response inhibition. Okay. So let's kind of summarize here. It's about 10, and we'll go on to the major theorists, and we'll probably take a break then, and then I'll go into CPTs and everything else from that point and see how we're doing. Let's take a look. Attention involves at least two separate neural systems that we as clinicians have to address in our history taking. We have to also address them in our assessments for ourselves. Activation and arousal. Okay. Again, it's thought to be, we neuropsychologists are great with coming up locations with a whole string of qualifications for them. So generally speaking, typically it's thought to be centered in the left hemisphere, involved in sequential analytical operations, at least in a Lyrian model. Okay. That's the activation. Arousal tends to be right hemisphere in the sense of feedback loops we're talking about for ourselves. Now, they tend to be parallel holistic. Now, if you're familiar with Doss's work, and then the work by Kaufman on the Kaufman Assessment Battery for Children, this gets into that simultaneous sequential processing idea that Doss proposed and has been used in the Doss battery and the KBC, for example. It really is sequential, and sequential is 1, 2, 3, 4. For example, another sequential kind of task is the digit spin. It's sequential. The information is given one at a time. The arousal, again, is at the right hemisphere, and that tends to be much more holistic, but simultaneous is another word I would use rather than holistic, because holistic, especially this day and age, conjures up a different kind of meaningfulness, using two words you probably hear a lot up here, holistic and meaningfulness, model. Think of it as simultaneous, and that is when all the information is given to you all at once, what can you do with it? Okay. That's the idea that it deals with. Okay. First is one digit at a time. Here's that. So if you're familiar with the KBC, for example, their version of the picture arrangement is a lot different than that of the Wechsler scales. Okay. You get all the information, you get to spread it out, and you bring it back together into one whole piece. Okay. Now, let's jump back into where we started before this little road of history and take a look at this, because these models here we're going to talk about really are the dominant ones today, and they are evolving, or they evolved from this historical route we just took for ourselves. But if we're going to treat and assess individuals I probably should put that in a better term, but we're going to take histories, assess, and then treat would be the proper model of saying it. Then we should have some conceptual formation for what we're doing, not only for the assessment process, but for the treatment process. I don't know about you, but I hear all sorts of wacky things, and hopefully I'm not going to offend only a few people. I usually offend more, but you know, I remember early days when we were doing work with autism, when we got into the model of diet coming up, and then who was that guy with diet? He's still around. Fine, that's it. In the early days, he would have these kids eating okra. Now, I don't know about you, but I would abandon my autism if I could avoid eating raw okra, okay? That model has crept into ADHD treatment as well. That theoretical link is that it's related into neurochemical processing, which are dietary. Thus, if we could control that, then all these other functions should come back into place. Okay. There's real lack of evidence for that. I'll just be polite and put it that way. And okra is best in Cajun food. Okay, well spiced, and you can't see it or taste it. Okay. If you haven't had it, go treat yourself. These are the dominant models here. Inattention emerges alongside a general pattern of impulsiveness and hyperactivity. Inattention, but look at that, emerges alongside of. So we have pathways here, and alongside, kind of, and I use the model in the middle of this, is this idea of inattention. But we still have impulsiveness and hyperactivity anyway on these roads. Deficits in self-control lead to secondary impairments in 4 executive functions. And here's the heart of Barclay's model coming up. Nonverbal working memory. Verbal working memory. Basically self-regulation of emotions and motivation. And then generativity or reconstruction. Kind of sounds like he had an Erickson moment there, didn't it? Reconstruction or generativity. Where we deal with play and rehearsal and those things like that. But these are the 4 basic categories or 4 basic functions of executive domain of dealing with attention. They have to lead us to these areas. There has to be some disruptions of nonverbal working memory, verbal working memory, motivation, and motivation is really arousal and intent. Okay, that's really motivation. Okay. I like to use those words rather than motivation because I'm sure if you consult with teachers in classrooms, it's just that he's just not trying hard enough, that phenomena. Well, I think more disorders of intention, disorders of arousal might be there as components. And then this area, we're going to go over each one of those here for ourselves. Barclay says the first one really deals with this, well, let me back up. Those 4 phases, those 4 steps, really have these 3 overriding characteristics. First of all, we look at basic neural functioning. They tend to be basal ganglia oriented. Okay, now, those of you who aren't familiar with the basal ganglia, I prefer that over okra. It's a nice medial feedback loop, feeding back loops to the thalamic area and the hypothalamic area. And again, what we're dealing with is sensory relay switchboard information, the ability to deal with that sensory switchboard, generally speaking, okay? If we say that that's what it is, and that's what studies show, then the pathways are clearly dopaminergic, with a little serotonergic rising on the cusp. How's that? Because you can't have one without the other. Disinhibition is the key factor to the etiology. So these are the 3 components that we just got from the 4. If we look at function areas, it's basal ganglia primarily. If it's that, then it's primarily dopaminergic, Barclay says. And then the idea is disinhibition. Disinhibition interrupts all 4 of those areas. And then your goal is to look at those 4 areas and find out where the disruption is. That means then, according to Russ Barkley and Mike Gordon, that ADHD is a long-standing, pervasive, chronically impairing consequence of poor inhibition and or intention. That's an important element, because as we get into Tom Brown a little bit, you'll see where the difference comes in. Long-standing, pervasive, and chronically impairing. That's a little hyperbole on the fact that they want people to be consistent with DSM-4 criteria, and that is age 7. It can't begin at age 35 when you use your job, they say. It has to be long-standing, pervasive, and chronically impairing, i.e. before age 7. You know, if you get through DSM-4, the criteria, you've got to look at the other things. You should look at the whole box when we take a look at this. And it's this last one that is often overlooked by clinicians. And that's why Russ and Mike make this point so pronounced. That's why history is a key thing. Okay. If it's not there prior to age 7, you know, you can do a little bit on the cusp at 8 if you want. Maybe it was just latent at age 7 and appeared at 8, I don't know. But it has to occur developmentally is what they're saying. It has to be a long developmental problem. And that gets into those things we just spent an hour talking about historically. That is the development of the neural structure so that you can have attention. That's what they're summarizing right here by saying this. It's not socially driven. It's socially displayed. It's not just situational. It's pervasive. Pervasively impairing, not just one situation alone. So those 3 words are very important. Because you will have times children who are ADHD at home, but not anywhere else. 2 things to take a look at. It may be that the child truly is ADHD and the teacher does a much better job of teaching inhibition. Or that's where you as therapists can jump in with histories and reviews and look at the family structures and histories. Okay. And if you do that history and they're only impaired there, they're not impaired anywhere else, they're not impaired in the community, they're not impaired in the church, they're not impaired anywhere else, that's a flag. Okay. That's not pervasive. Okay. It may have been there before age 7, that's because the kid's lived in the family all of his life. But it's not pervasive. Pervasive means it's going to show up in more than one spot. It's not just situational. Okay? And that's, again, use your family therapy skills and things to take a look at some things. But also look at your detective skills, and that is take a look at, is someone else doing a better job of teaching inhibition? Remember, parental discipline is there to impose some sense of, usually, over-drastic model of inhibition, and punitive model. But if the child isn't profiting from it, it ain't working. It's not going to work. Stop it. Teach a model that does work. Because the goal, again, is self-discipline. ADHD kids have a problem with self-discipline in that sense. It's pervasively a problem. There are ADHD adults because they were ADHD kids. You know, back in the days when I was at Tyke in psychology, we were taught that ADHD magically disappeared at puberty. You know, it doesn't go away. What happens is the kids go away. Okay, and the home is restored, and that's nice. Okay, but it doesn't go away. You look at the adult literature, these kids who have this pervasive, chronic, long-standing problem have job turnovers, you know, they have problems with addictions and the like. Okay, they have problems with multiple relationships, things like that. It's a chronic problem. Now, it may not be hyperactive. They may have learned some motor inhibition because the system brought that to them anyway. But they're still ADHD. Okay? It doesn't go away anymore. Brown's model is purely inattentive. It stresses that there's he's clear on this, and this is aimed at Russ and at Mike. There's an over-focus on disinhibition. There's an over-focus and an underappreciation of arousal, activation, and working memory. The big thing is the bottom. It can begin after age 7. There's no magical age for these symptoms to appear. So if we look at the Brown scales, now I do a lot of test construction. I'm not sure I want my test to be known as the BADS test, but the Brown Attention Deficit Disorder Scale, as it calls it. There's no age requisite in that sense. If we look at the behaviors, okay, they can occur after age 7. Doesn't have to be developmentally sane. He says this overfocus on inhibition, which always has its roots back in neurodevelopment and brain development, he says it's been too strongly focused. And this is the conflict that exists right here. This age 7 is a big issue, but nested in that issue is the idea, well, what's the big deal? Well, the big deal is it's not necessarily failure to learn to inhibit, or i.e. disinhibition. We really haven't looked at arousal, he says. And arousal problems come up. Now, if you've been following the literature, where this goes in multiple passes is that, and sometimes again to the comical extreme just to make a point, but if we do look at this, then depression is a problem with arousal, and you can be depressed and have problems with sustained attention and concentration because that's one of the first things DSM-4 asks for in the DSM-4 depression. Therefore, you can be ADHD with that. Okay. Now, some of you have some, what did he just say? But if we look at what's being said here, that's what's being said. I personally have some difficulties, although Tom and I are good drinking buddies. We do a lot together. We have an article coming out together. But I have a difficulty with this model. Maybe just my latent inhibition training or lack of learning inhibition, one of the problems, but it's a problem. ADHD, Brown says, includes inattentive individuals who are not impulsive. Well, again, with adults, again, usually by age 7, 8, or 9, the impulsivity in the sense of hyperactivity goes down. But that doesn't mean the child has learned inhibition. It leads to other disorders of impulse. At extreme ends, again, episodic discontrol issues. Those are clearly disinhibition problems. Or other aspects. Okay. As he says, all inattention is ADD or ADHD. All inattention. Again, my concern with this comes in that, again, DSM-4, first statement for depression is must be problems of sustained attention and concentration. Same thing for anxiety, and it must be pervasive in the sense of impaired daily functions of living. Typically, he would say that meets the criteria, but those symptoms really are ADHD-like symptoms. It's a broad range then, and thus his rating scale fits his theoretical orientation. It's modeled upon that theoretical orientation. Go ahead.
Isn't his emphasis also on comorbidity? So
right.
It seems as though he looks at overlaps with those things rather than being quite as simplistic.
Well, you're right. Because where he goes with that is that, yeah, they are. Now our goal is, if you didn't hear him, he said was, where Tom is going with it now is comorbidity of disorders, is saying, okay, let's take a look and tease out some commonness. Okay. There may be a common root here in the sense of etiology for himself, he's saying. And he certainly would encourage you to make sure it's not depression, since he publishes with Psych, or he would say to give the bet and things to make sure. But the root is the same. And that clearly is a different pathway than Russ Barkley and Mike Gordon take. Okay. You know, you look around my age, although younger than me, I'll be polite, is that most of us grew up with Saturday Night Live. Remember Jane, having this dialogue on the Saturday Night Live newscast at night. Those guys are like that sometimes at APA meetings. In the sense of the dialogue back and forth. I mean, it's quite robust. I mean, they talk to each other civilly, but the points are well taken. They're opposed positions. Okay. And it's important for you then to take a look at your own clinical practices. Where do I fall within that? And in this sense, this tends to be that more psychiatric approach that I started with in the sense of history. We talked about Broadbent and the other psychiatric models. This tends to fall into that typical psychiatric model. In the sense of, did you get the handouts? They're in the back. Do you have them? And the first slide, what we talked about was, the first ones talked about the psychiatric models. My cover is back. Oh, no, they're here. I just don't want to go back through all the slides, make you dizzy going backwards. But in the early slides, you'll see, and if you run out, I'll get more, I'll email them to you. Those of you who were not here at the beginning, if you want to come up and leave me your card or address, I'll also email you the PowerPoint packages. The early slides, I think it's page 1 or 2, depends, talk about that the psychic models, 3 components of attention: selectivity, capacity, sustained concentration, not inhibition itself. It's arousal, it's not inhibition is the problem. It fits the real problem. And then I think on it's on the end, and that slide there, that's why. Because it's not the inhibition pathway. The psychiatric model is typically the arousal model itself. And when I'm telling you it's psychiatric, I'm just, although I have to be careful because sometimes psychiatric groups are not necessarily my best friends. As a psychologist and neuropsychologist, tend to walk in different pathways and different sides of legal issues, especially prescription issues. But that model tends to favor arousal rather than disinhibition. That's why. Yes. Okay. Executive dysfunction is still a problem. We get back into this Lurian model, the new executive function model. It still has this feedback loop coming back in, but it comes back into arousal, not to inhibition. Right? And this really then is really not a basal ganglia or dopaminergic kind of a model either, because of that, because it's not a disinhibition model. 5 major clusters: organizing, sustained attention, sustaining energy, managing affective interference, and utilizing working memory and recall. And if you're familiar with Tom's test, if we look at these are actually 5 clusters or factors that his test items draw or pull out symptoms and related behaviors related to these 5 clusters itself. And so he's done a nice job with that in the sense of his instrument. We've actually found some nice things using his college students and my test of variables of attention auditory processing test, looking at variability itself, and there are some significant correlations there with our test and his in the college population, and that's what the article we're looking at. Well, let's take a look. Inattention is some criticism of this, and again, Mike Gordon. Again, Mike is a nice chap. He's up at Syracuse. Mike is the developer of the Gordon Diagnostic System, or the GDS. This is familiar. Mike has done some wonderful work with ADHD. And any of you are working with ADHD, especially with adults, in the sense of how it fits into the court standards for disabilities. Mike has done some very good pivotal work on understanding that, putting together, organizing it. That's very helpful for you formulating your cases. So I encourage you to look at his literature to help you. But I think it's a pretty broad statement he makes here. He says, inattention is the king of all non-specific symptoms. Okay. Inattention can emerge from any of those areas, medical and psychiatric circumstances. Okay. And Mike and then Russell's point is, and mine also on this, is that if we look at this, though, especially this last one, remember the other part of DSM-4 is that one of the other things, in addition to age 7, the other thing it says is that it cannot best be related to some other medical or psychiatric cause or etiology. Okay. that's the problem I have with Tom in that sense. Well, we need to work on that. And he does look in the sense of teasing out other disorders, and that's essential, and he will certainly tell you that, to do that. But if we look at arousal alone is only really, I think, a part of the problem. We have to take a look at inhibition. If we just look at arousal, I think we have some serious, we have some problems. I don't want to overly stress serious, but we do have some problems in the sense of what is going on, because disinhibition is clearly a problem. That is also going to get into some treatment issues for yourself. So take a look at yourself on this continuum of where you fit for yourselves, and gee, what am I? I tend to be more this inhibition model, inhibition and arousal, or I tend to be more arousal-oriented. What's the real issue here for myself? But again, inattention is the king of all nonspecific symptoms. Inattention is a problem of everything, in some sense, but the king of nothing. So let's kind of summarize, take a look at some clinical care things for ourselves. History is very important. These are early life predictors. And again, take a look at those early life routines. Those histories are important. Sometimes it's very hard, as we know in our culture, in our societies nowadays. People who are parenting may not have been around when that child was young. It's difficult sometimes. Okay. And again, adoptions present problems in and of themselves. We don't have those historical roots to take a look at. So genetic trees are important. Motor hyperactivity in early age is important. That's a disinhibition issue. Did that motor activity attend itself to any kind of inhibition structure? Redirecting a child sometimes, that's inhibition. If it begins to dissipate, then that child is capable of learning, and that problem should on its own dissipate by the end of age 7. It shouldn't be a continued problem developmentally. Also keep in mind that it's one by exclusion. Okay, low APGARs typically produce, Canada uses APGAR? Yes? Yeah? I guess we have a word to say. Okay. Behaviors that mimic ADHD, but a different etiology. Okay. Hypoxia mimics ADHD, different etiology. Again, that DSM-4 requirement is it's not best described or explained by something else. Central nervous system diseases itself are problematic. Obviously, head injuries, loss of consciousness. I've seen some articles talk about acquired ADHD by head injury. I struggle with that. For me, it'd be acquired ADHD symptoms rather than a diagnosis. Really, a proper way of saying that, because again, brain injury is not ADHD. The behaviors mimic each other, the symptoms mimic each other, but a different etiology. You may end up treating them the same, but I'm kind of an academic theorist at that point. Metabolic disorders, seizure disorders, apneas, other medical conditions. There are studies looking at apneas in ADHD children, and there's a much more prevalent rate of sleep apneas than what we thought. It's not just related to us people over 40 or 50 anymore, but apneas occur at any age. Apneas produce ADHD-like symptoms. Don't be afraid to ask that when you look at histories. Have the families observe the child when they're sleeping. Okay? Because the treatment's going to be different. Okay? CPAPs do work with kids too. Again, I stress it's by exclusion here. I have about 10:23. I'm going to go through a couple more if you want and take a little break. I'm not sure what's set up out there yet, but that'll give us about a halfway point if that's okay with everybody. Okay. Again, these things have to be there. It's diagnosed when disorders do not best account for the symptoms. The symptoms may be the same, etiology, though, may be similar or it may be different. The treatment may even be the same, but it's not ADHD, it's due to something else. It's pretty simple, straightforward.